Dr. Shepard, we have several questions already for you. As it relates to Healthy Babies Are Worth the Wait, we noticed that it targets multiple audiences ranging from healthcare providers to pregnant women to the general public. How have you met the challenges of communicating the same message to all these different groups? And what's been the most helpful for you in crafting these messages, and what didn't work so well?
Well, I think what did work was just the title, Healthy Babies Are Worth the Wait. I mean, everybody identifies with healthy babies, and everybody does know somebody who's had a preterm birth. And any family who's been through that would not wish that on other families, even though many of those babies do quite well. The most engaging message was the brain development in those last 4 to 6 weeks of pregnancy and the massive amount of development that takes place. And the brain card really was useful. Everybody understands, you know, you can just visually look at that and see the differences in the brain at 35 weeks and at term. And much like, you know, brain development was the issue that drove all of the new interest in early childhood and creating enriching environments in early childhood, the brain development in those last 4 to 6 weeks of pregnancy should be just as important. And we found it was an engaging message for communities at all levels, as well as for the patients and the providers.
Thank you, Dr. Shepard. We have another question for you. You and your team have implemented what sounds like a very robust evaluation process. How has this investment benefited the program to date, and are there any additional elements that you wish you had incorporated in your original design?
Well, when we started this project, we knew it would be difficult to evaluate because it's difficult to measure, you know, what's happening from bundled interventions and knowing which intervention did what. So we knew from the beginning it would be a struggle, and we basically tried to do all the things that we thought might give us a handle on whether we were having an effect. In retrospect, we probably didn't need all those measures. We did find some evidence that we changed provider behavior in the implementation sites, that we raised awareness in the implementation sites, but it was probably not worth all the trouble it took to do. We surveyed literally thousands of people, both before and after the project, and probably in terms of you know, getting the most out of those efforts, we found that it was probably better to use existing data and local data. You know, everybody tracks their referral numbers to the different programs, and local data was really the most useful in determining what was working well and what was improving in terms of referral numbers and what wasn't. And then we had a lot of personal stories which were very compelling about people doctors who weren't convinced of this and then delivered a baby early that ended up on an ECMO and were convinced then that it was an issue. So people really were most pleased with the personal stories, and that was the most motivating to the people working on this.
Thanks, Dr. Shepard. A third question here. Your collaboration with the March of Dimes and the Johnson & Johnson Pediatric Institute and other public and private partners, I think, demonstrates clearly how powerful and effective partnerships can be. From your perspective, what's the secret to the success in Kentucky, and what advice would you give others looking to foster effective partnerships?
Well, I think one of the wins in this was certainly the partnerships, and we had great partners. You know, Johnson & Johnson does infant mortality projects literally all around the world, and everyone knows the March of Dimes expertise in prematurity prevention. But I think what was most helpful to us is that prematurity prevention is something that everybody thinks is important. You know, we don't want babies to die. We don't want babies to have lifelong disability. And so for the people that you call in to be partners, I think they're immediately engaged and involved in this. And I think that really was the key for this project, was to have the right topic that people could engage in, and just explaining to them the significance of it. They really bought in very quickly.
Thank you, Dr. Shepard. Obviously, the partnerships were key in the success that you experienced, and thanks for that follow-up. Another question, will you talk a little bit about how you customize the interventions at each different site?
Sure. For instance, with oral health, you know, there is a link between oral health being a chronic inflammatory disease and preterm birth. We had one site where they couldn't get any local dentist to see a woman on Medicaid, especially a pregnant woman on Medicaid. And so what we did there was we had a combined meeting of the Dental Society and the local ACOG chapter, and they had an expert come in and talk to them about oral health in pregnancy and what was safe to do and what wasn't safe to do. And following that, they were able to work out referrals to a number of the local dentists. In another site, they actually had a dental chair in the Women's Health Center, but when the Public Health Department opened up a dental clinic with 5 chairs, they decided they would send their patients over to the dental clinic. I mean, it was within sight of the hospital. It was less than a block away. But what they found out was the women didn't go. And so what they ended up doing was bringing the dental hygienist and the dentist at specific times back over to the hospital dental chair to see the pregnant women when they were coming in for other things.
Yeah. Thanks, Dr. Shepard. There's more questions coming in from our audience. The next question, with the improvement of neonatal resources and technology, previous unviable births are now live births. How do you incorporate this phenomenon when determining trends and targets for infant mortality and preterm births?
Well, I think the goal is to prevent those extremely preterm infants as well as the bigger preterm infants. And I think that's one of the places where, as we work on social determinants of health, I think we're going to find more impact. Certainly those are a contributor to infant mortality, but the point is that we need to have better systems of care so that we don't have those extremely preterm births, and we don't have preterm births at the higher end either. But I think what we found was that working on our systems of care, again, we reduced the overall preterm birth rates, even though we talked a lot in the project just about the late preterm births. But as you call people to work on ACOG guidelines, and in the social sector we call people to get the supports in there that families need, we found that worked very well to improve both the extreme prematurity and the late prematurity.